Hi, I'm Dr. Varun Sundaram. I'm Section Chief of Advanced Heart Failure at the Cleveland VA Medical Center and a cardiologist at the University Hospital's Harrington Heart and Vascular Institute and an associate professor of medicine at the Case Western Reserve University. So the study which we looked at was called the Transform AF study, where we investigated the relationship between GLP-1 receptor agonist use and the burden of atrial fibrillation in patients with pre-existing atrial fibrillation and a body mass index of greater than 30. Even with the most recent and modern ablation techniques, almost one third of patients with atrial fibrillation have a recurrence after ablation. And this is just within a year of follow-up. So this would mean most patients live for at least 2 decades post-ablation and are likely to experience recurrence of atrial fibrillation, therefore necessitating another procedure. So this, we believe, is likely related to progressive atrial remodeling, substrate remodeling that persists despite initial procedural success with ablation. So what we all think and the evidence shows is this recurrence or progressive substrate remodeling is largely related to suboptimally controlled cardiometabolic risk factors, with obesity being the predominant driver in the Western population. So this importance of the study is to reduce the residual risk or to investigate what the effect of GLP-1 use in reducing the residual risk of atrial fibrillation in patients with pre-existing atrial fibrillation and a body mass index of greater than 30. So it's a pharmacoepidemiological study. It's a multi-center pharmacoepidemiological study involving patients from 170 Veteran Affairs medical centers within the United States. And what we first identified was a base cohort of patients with type 2 diabetes, which is close to 1.5 million patients with type 2 diabetes within the Veteran Affairs health system, and those with atrial fibrillation and a body mass index of greater than 30. So this formed the base cohort. And the reason for picking diabetes is type 2 diabetic patients is because that's the reason why GLP-1 receptor agonist was prescribed during the study period. From this base cohort of patients with atrial fibrillation, what we identified was those with new initiations of GLP-1 receptor agonists and compared them with a comparator group, which included those with new initiations of DPP-4 inhibitor or sulfonylurea. And we followed them up for a primary outcome, which was time to hospitalization for atrial fibrillation with the primary diagnosis and AF-related procedures. So the key findings of this study was during this median follow-up of 3.2 years, uh, we accumulated more than 320 AF-related events, giving good statistical power to answer the question. And what we observed was a 13% reduction in the residual risk of AF-related events with the use of GLP-1 receptor agonist. And and the important aspects of this was observed with just a modest incremental weight loss with GLP-1 receptor agonists. The group with GLP-1 receptor agonists had only 4% weight loss because these were diabetes management doses, suggesting a pleiotropic effect of GLP-1 in reducing the burden of AF in patients with pre-existing AF. So as mentioned earlier, the residual risk of atrial fibrillation in patients undergoing procedures for AF is quite high. And while ablation is phenomenal in acute procedural success or acute termination of atrial fibrillation, the issue is the long-term recurrence rates still is not trivial and quite substantially high, frankly, in a large proportion of patients. So what we believe is needed is a multimodal approach of one, rhythm control strategies with ablation for patients with atrial fibrillation, coupled with substrate, targeting the substrate with controlling the risk factors. And what we believe is, with the results of the study, is GLP-1 receptor agonists could be used in these patients, predominantly starting with patients who are going for AF ablation, using obesity as an indication, and to improve long-term outcomes. So while this is a multi-center pharmacoepidemiological study, The study comes with limitations. One of the key limitations which I would like to emphasize is the non-randomized nature. And that means it's not immune to residual confounding. And a large part of the important finding should be viewed as hypothesis generating. Having said that, a randomized trial in this area, especially in the United States and in Western Europe, might be quite challenging to do for important reason being it's going to be extremely difficult to randomize patients who are obese to a control group who would not be receiving GLP-1 receptor agonists. And this study would mean would require a long follow-up as you're modifying a risk factor and looking for changes in outcomes. So that would mean a long-term follow-up of patients with body mass index of greater than 30 in a control group with no GLP-1 receptor agonists might be quite challenging in terms of recruitment and subsequent follow-up with no reliable crossovers. So that's a limitation and forming a prospective randomized trial in this fashion. But what is important is there is still clinical uncertainty in the group with a body mass index of less than 30 who still have visceral adiposity and atrial fibrillation, where GLP-1 receptor agonists could be um, uh, could be useful in reducing the long-term burden of atrial fibrillation. That's one group which I think ought to be studied, and still have having said with the limitations of conducting or the feasibility, we should still attempt to perform a prospective randomized trial in this area to answer this question definitively.